So good morning, everyone. Welcome to this session on diaphragm protective ventilation. We wanted to do this a little bit different. So we have exactly 0 slides. What we want to try to do is just make this an interactive session. I'm sure that during this conference you have seen like 1,000,000 slides, so we're going to do it a little bit different. I'm going to interview 2 real experts in the field of diaphragm pathology, diaphragm protective ventilation, etc. So I'm happy to introduce Professor Jamil Chabert from Montpellier.
Hello, good morning.
And Professor Ewan Gallagher from Toronto, Canada.
Hi, everyone. Morning.
So I'm going to start to ask them a couple of, and my name is Leo Heungs from Rotterdam. I'm going to ask them a couple of questions, but please interrupt and make this interactive as possible. We have 30 minutes. I'm sure it's going to be very exciting. So first, Samir, can I ask you, can you discuss a little bit what is happening to the diaphragm in patients that are admitted to the ICU? What's the impact of critical illness on the diaphragm?
Thank you very much, Leo, for this major question for a physician that should manage it every day. Some patient, first of all, when a patient arrive in your intensive care unit and this patient need invasive mechanical ventilation and you will need sedation, that you will induce the muscles and mainly the respiratory muscles, mainly the inspiratory muscles should be at rest. So if you put any muscles at rest, you will develop an atrophy. This is the first mechanism, whatever you use it. So more you have no breathing, more you have less spontaneous breathing by the patient, more first you increase the atrophy. Right. This is a simple way to have the first answer. Then second is the impact of this. The impact of this is when you have atrophy, you have less forces, then the muscles develop less force, and then it will be an impact on the weaning process because the patient probably have less force. And this will be worsened by the pathology of the patient, that now we have several data suggesting and demonstrated that, for example, sepsis versus non-sepsis, you have more atrophy, you have more proteolysis, you have more effect, you have more, for example, oxidative stress. On all these mechanisms, it's too much complicated, but the results for clinician, it's when you have a weaning process, you have less force for the muscles, and then you can delay the extubation and you worsen the outcome. This is a briefly introduction.
Okay, so I think that...
I don't know if...
yeah, sure. So this is a very important point. Inactivity of the diaphragm results in atrophy, and I think it has been shown in a landmark paper published in the New England Journal of Medicine by Levine, right? But Ewan, is this the most important factor in activity, or do you think that other factors are at least as important, or at least play an important role in the development of what we would say critical illness associated diaphragm weakness?
Yes, that's an interesting question. I mean, there's clearly many factors that impact on the diaphragm. I think the 2 principal ones being sepsis, and then the abnormal levels of respiratory effort that we see under mechanical ventilation. And I think there's quite good data suggesting that both inactivity and excessive respiratory effort contribute to diaphragm atrophy or injury during mechanical ventilation, or myotrauma as we sometimes call it. So the question is, which is the most significant or predominant factor? I think it's a hard question to answer with certainty. It's clear that many patients develop diaphragm atrophy during ventilation, upwards of 40% in some of our previous cohort studies, and maybe possibly a smaller percentage of patients who clearly develop evidence of what we think is load-induced injury. But I suspect, to be honest with you, that these 2 mechanisms sort of overlap a lot and occur and are sustained at different time points. So you might initially be on the ventilator, have very low levels of effort, develop atrophy, and if anything, that's going to predispose you to load-induced injury when it's time to start breathing. And interestingly, the emerging data seems to suggest that patients transition from passive apnea under ventilation to extremely high levels of respiratory effort. And there's not that many patients who are sort of in the happy medium in between unless we're really paying attention to this. So both of these factors are important, I think.
Okay, so can I ask the audience, do you agree with the statement that we should, from a diaphragm perspective, keep the time on controlled ventilation, that the diaphragm is completely inactive, as short as possible? Does anyone dare to comment or have an idea on that? Everybody agrees that we should keep it as short as possible? Well, perhaps I can ask you, Samir. There's an interesting study, of course, from France, from Laurent Papazian, showing that 48 hours of neuromuscular blockade, inactivity of the diaphragm, does not delay the weaning process. So isn't that an argument against the idea that disuse is bad for the respiratory muscles?
This is a very important question about the effect of all sedation, in fact, and you focus on specifically the neurorelaxant. You're right, we discussed a lot with Laurent Papazian about the benefit of neurorelaxant neuromuscular blockage during the first or the 2 first days of RDS patient, and we observed a benefit in terms of outcome without any significantly more neuromyopathy or more diaphragm dysfunction at day 30, day 60, and day 90. Some data are not published because we work a lot with Laurent Papazian. And then probably we could speculate, but difficult to confirm, that a short period of neuroaction may not influence. And then the balance between benefit risk is in favor to use for a short period. I think that not exceeded 2 days. We hope that the status of the patient improve. Then you should first of all treat the etiology of the acute illness of the patient. And the data suggests that short period, slowly or not a lot of influence the impact of diaphragm dysfunction. This we can today disease. But you have the question about all sedation, the hypnotic drugs, the morphinic drugs. We have some data suggesting positive or negative effect, for example, of the propofol, and it depends also of the duration of administration. So the message, you're right, you should absolutely try to treat correctly the pathology. It is an ARDS of pneumonia A, of COVID, of anything, pancreatitis. Then this, when you treat efficiently this one, you should try as early as possible to return to a spontaneous breathing with the respect, as clearly said by A1, to avoid excessive inspiratory effort. So it's a U-shaped curve, not high inspiratory effort made by the patients, not too low induced atrophy, too high induced, as said clearly by A1 and the nice data they have, induced probably so-called SILFI, self-induced lung, but also diaphragm injury. And then now that's why A1 and all the group speak not only on the diaphragm, but probably I like the concept of both diaphragm and lung because it's very similar, and maybe we have a delay of 20 years from VILI and VIDD, but they're the same. I don't know if Ewan, you want to complete?
Yeah, I would make 2 comments about this. So the first one, it's very interesting to think about the control group who did not get neuromuscular blockade. We really have no information on how much diaphragm activity was actually present in the control group. And I suspect, given practice at the time that the trial was done, et cetera, that many of those patients were also apneic. And of course, we don't really even know what the actual mechanism of benefit of neuromuscular blockade. Furthermore, the more recent ROSE trial, which was much larger, didn't really substantiate the benefits. So it's hard to interpret that trial in the first place. But the other thing that that we've described, which is a very interesting issue from my standpoint, highlights this issue of the interaction between the lung and the diaphragm, is in our data set, patients who were exposed to neuromuscular blockade had on average no difference in survival to ICU discharge. But if you subdivide the patients into two groups, those with a higher baseline diaphragm thickness and those with a lower baseline diaphragm thickness, there was a significant mortality benefit in those with high baseline diaphragm thickness and significant signal for harm in those with low baseline diaphragm thickness. And we think that actually the baseline diaphragm thickness, if anything, might be a useful way of predicting whether or not a patient's at risk for patient self-inflicted lung injury, because you need a strong diaphragm to generate the forces necessary to overdistend the lung. So it's very, very clear that the diaphragm matters, the lung matters, but the interaction between these two organs that sit adjacent to each other needs to be very closely attended to in managing these patients. It makes the problem complex, but also very interesting.
Thank you. Yes, there's a question.
So if I understand correctly, you think that the fact that the weaning was not affected as a general is because of a reserve and not because of the ability of the diaphragm to recover fast as a muscle. What I mean to say is that for sure there is an atrophy, but the fact that the weaning was not affected dramatically could mean two things. One, there was enough reserve despite the atrophy. The second option is that this muscle has a special ability to recover.
So is that question in response to what I just said? Okay, because I think you may have misunderstood what I just said. What I was talking about is the association between exposure to neuromuscular blockade and mortality.
You explained that the people with the high thickness, that means that they had high reserve. So despite the fact that they may have been affected by the neuromuscular blockade, they still have enough reserve to recover. So you didn't see it on the weaning process. While the ones with a very low thickness, those are the ones with no reserve. And then that's why the neuromuscular blockade have affected them.
Okay, so that's a very thoughtful question. I'm going to make it even more complicated for you. Because the interesting thing is that patients with high baseline thickness are also the ones more predisposed to atrophy. And among patients with high baseline thickness who develop atrophy, their weaning is more prolonged than patients with high baseline thickness who don't develop atrophy. So this is the challenge. We're protecting the lung to improve survival. We're protecting the diaphragm to accelerate liberation from the ventilator. And you have to pay a price to do the one, and with respect to the other, you have to, in order to save the lung, we're paying a price on the diaphragm. And I think the real question for us now is, can we find a way to thread this needle so we can protect both at the same time? Can we keep the diaphragm active while also avoiding excess lung distending pressure? And doing that with ventilation versus other adjunctive strategies is sort of the next phase of research in this area.
Other questions? Yes.
So thank you for your kind explanation about this. I have a question about excessive respiration in patients or on support mode. What would be the best strategy to lower their respiratory drive? Is it more in sedation, or is there a specifically target for partial neuromuscular blockade?
It's a great question.
It's a very important question. Thank you very much. My main message, you should always treat the etiology of the illness. I'm afraid sometimes because the resident always treats the symptom, and you should absolutely separate symptom and etiology. So probably one will speak, and Leo speak about the paper, very interesting in the Blue Journal, about using small doses of myorelaxant to try to decrease the high inspiratory demand and to limit the side effect on the myotrauma and the diaphragm. This is a very nice concept, but I don't like it. I don't like it. I absolutely don't like it in a physiological point of view, because I saw in several departments, and especially in my unit, that when the patients, you observe it an asynchrony, the patient have a high demand, you see that high peak inspiratory flow. The first thing that some resident and some, I don't know, junior, maybe some senior doctors, sorry, said, oh, I read the very nice paper and I will use neurolaxant. I said, no, it's not the good reaction. The good reaction is why the patient have a high inspiratory demand. Why? This is the first question. Is it a start of a new infection? Is it a start of a new sepsis severe? Is it it's a signal. It's a surrogate of something. You should see what happened on the lactate, on the glutathione gases. Is it hypercapnia patient? Is this, I don't know, the tube not, I don't know if there is some problem in the ventilator. This is the first reaction. If in a postoperative patient, is there any surgical complication, and so, and so, and so. And when you made all this action, if you put a CT scan and discuss with the surgeon, with other things, then you said, now we should try to discuss about the sedation. I always said that sedation and weaning is always a couple, not separable. So I think it's a good idea in this case, after you eliminate every cause of high inspiratory demand, and then you can set to avoid self-induced diaphragm injury by high depression, high inspiratory effort, high swing. This is probably interesting using sedation, neurolaxant or not, for have the diagnosis. I don't know if you agree, my friend Leo, Ewan.
Can we have another short question, because there's another topic I want to address.
Sure. Can I just emphasize that adjusting PEEP can have a very important effect on respiratory effort, and that's definitely something to pay attention to.
There is a trend in any patient getting ventilation, try assist control mode, then support mode. But while we are saying that the diaphragm activity is important, if you keep the diaphragm inactive, and from day one it starts getting atrophy. So that's in animal study, it has been proved. So my question is, instead of going for assist control, SIMB pressure support from day one, and with if you can regulate the SIMB rate, and you can initiate the pressure support with the activity of the diaphragm in whatever form, is it good for patients? And in the long run, it's going to give you extra effort to have a winning process?
So, I think I don't think the mode is finally the most important thing, because a patient can be breathing spontaneously under an assist control mode, like volume control or pressure control, as you know. And it really just depends how you apply that mode, what inspiratory flow you set. In volume control, for example, has a big effect on the patient's effort. The rate that you set, the pH and PCO2 that you're targeting. I think many patients are passively ventilated just because we ventilate them to a normal blood gas. And if we would just reduce our respiratory rate in these modes, the patient would start to trigger and breathe, and we could avoid some of this diaphragm activity. So at the end of the day, I don't think the answer is getting the patient into pressure support per se, because even in pressure support, we have data showing that patients develop atrophy if their inspiratory effort is excessively suppressed. It's optimizing the way you're applying the ventilator to achieve the right level of respiratory effort. And absolutely, I do think if at all possible, we should be doing that from the moment the patient gets put on the ventilator. So an interesting question is, for example, can we intubate patients in a way that avoids completely suppressing all respiratory drive, so that right from the onset of mechanical ventilation, we're keeping patients breathing and managing that more effectively.
Thank you. But perhaps I can summarize this first 20 minutes. I think we all agree that development of critical illness-associated diaphragm weakness is important. It has a clinical relevance, and that next to inflammation, an important contribution of inappropriate ventilator assist, right? Too much assist may result in atrophy. Less assist, too little assist may result in load-induced injury, or as Ewan calls it, myotrauma. If I think about this a little bit, then there's a very good rationale to monitor breathing effort, right? So let me ask you, who's actually monitoring breathing effort in the ICU, in your ventilated patients? You? Okay. How do you monitor effort of the diaphragm?
Looking at patient, even if they are ventilated, so look for the respiration rate, the accessory muscles, and whether it's a gasping or labor type of breathing, even with the ventilator. And then you know that patient's effort is, you haven't done much for the reducing work of breathing. So,
Anybody else monitoring respiratory muscle activity? Right here. Noah.
PO1.
Okay, so we have a clinical assessment, very important, P.1. Perhaps Ewan, you have a couple of papers on this topic, original work. Can you explain a little bit from a clinical perspective how you would monitor activity of the diaphragm in ventilated patients?
Yeah, I think we've made important progress actually in making this easier to do than it has been traditionally. So during assisted mechanical ventilation, the measurement that I rely on the most is something we call the expiratory occlusion pressure, or the POC. And it's very simple to measure. You essentially apply an expiratory occlusion or expiratory hold maneuver on the ventilator the same way that you would if you were measuring intrinsic PEEP during passive ventilation. And while you're applying the occlusion, if the patient is breathing, they'll make an inspiratory effort against the occluded airway, and the magnitude of the pressure that they generate during that occlusion predicts really quite accurately the level of respiratory effort they have during the assisted breaths. And so as it turns out, the data suggests that the P01 is very useful to detect insufficient effort. If your P01 is less than 1 centimeter of water, you probably have very low levels of respiratory effort and are at risk of diaphragm atrophy. But the POC is actually much more sensitive and specific for excessive respiratory effort. And what's interesting is if you basically take your POC and add it to the positive airway pressure swing, you get the total lung distending pressure, because now you've got the pressure being applied to the lung by the respiratory muscles and the pressure being applied to the lung by the ventilator. And when you start to monitor this, you realize that frequently the levels of driving pressure being applied to the lung during assisted ventilation by the patient are much, much higher than we'd ever tolerate during passive ventilation. So this is a big problem that we need to be paying more attention to. And I think these simple measurements like P01 and POC together make it very simple. So in my ICU, RRTs measure P01 and POC at every routine ventilation assessment as part of their assessment of the appropriateness of the ventilator settings. And I think now there's actually multiple papers emerging showing that these measurements are really quite useful and impressively reliable for simple clinical monitoring.
Yeah, I can really recommend Ewan's paper published in Critical Care, Michel Battoni as the first author. I think it's a really interesting paper discussing the occlusion pressure. Samir, do you have other techniques
Yes.
in your ICU?
It's like one, but I think I always surprised when we ask the audience what we do, what you do. And now in the last generation of the ventilator, you have the P01, very easy, just press on the button. But the PE max, it's, I don't know what's called for the different ventilator, the NIF, negative inspiratory force, inspiratory maximal pressure. This is a very simple to see the evolution when you start the process. When you stopped the sedation and the patient start, please use it. It's very simple. The normal, the physiological value when you, for me, for example, for the inspiratory effort, when you use it, the resistance, and try to make a maximal inspiratory effort is around 80 centimeter, maximum 100 for men and around 70, 18 for women. This is for normal physiological. for the patient in ICU, when you start the weaning process, you should and you could try to evaluate the first PE max or NIF, negative inspiratory force, and this is the surrogate of all inspiratory muscles, not only the diaphragm. And when you have a value less than 20 centimeter, less than minus 20 centimeter of water, the message is that the patient could not develop a force to mobilize volume, because you have the force and you have the endurance. This is very important. And you see the day after if it's increased, and when you reach to above more than minus 30 centimeters of water, then you could speculate that the patient could mobilize the volume. This is the force. So the spontaneous breathing trial evaluated not only the force, but evaluated the endurance. And this is different why we try to evaluate this for at least 30 minutes, 1 hour. And this is two concepts different. But we monitor this parameter with is a very simple usefulness, not the absolute value, but more than evolution.
Questions or comments? Yes, please.
I would like to understand better the values of the POC that you are troubled with, or you are concerned with.
Yeah, good question. So when the patient makes an inspiratory effort against an occluded airway, their diaphragm and respiratory muscles are making a quasi-isometric contraction, which means they generate more force than they would when the airway is open for the same level of effort or the same level of muscle activation. So to convert the POC to the respiratory muscle pressure, we have a correction factor where you multiply it by about 3/4. And that adjusts for the fact that this is a quasi-isometric muscle contraction. So the normal range of POC is something in the range of minus 10 to minus 20 centimeters of water, which is approximately equivalent to a PMUS of 5 to 15 centimeters of water, something like that. So that would be a sort of typical range of respiratory effort.
Thank you for this wonderful presentation. Two small questions. One specifically to you, Professor Gallagher. I learned that some of your major works considered also ultrasound of the diaphragm, and I just wonder how you see it in the future. Do you consider it as a method also in the clinic or only for research? That's my first question. And the second question to all three of you maybe, do you see any future, especially for proportional ventilation modes, NAVA, PAV+, for the concept of diaphragm and lung protective ventilation?
Mm-hmm. So great questions. I'm happy to address the first. Yeah, at this point, I think ultrasound has both research and clinical uses. From a clinical standpoint, I personally think it's the simplest and most feasible technique for assessing diaphragm function. So if I have a patient who's difficult to liberate from the ventilator and I'm concerned that they have diaphragmatic weakness, they've got a low negative inspiratory force, like Professor Jabert was talking about, then I'll use the ultrasound to evaluate the function of the diaphragm, measuring the maximal thickening of the muscle during inspiration. I'm not sure that daily measurements of diaphragm thickness are all that useful for clinical practice. I think they're incredibly useful in research. And it may be in time that somehow this becomes a relevant biomarker that can guide therapy and help us risk stratify patients and so on. But at this point, I think that probably makes more sense only in research. That's my point of view. I don't know if either of you think differently about that.
Perhaps I can ask one more question to clarify, because I think you're touching a very important point, right? The role of ultrasound to assess diaphragm function as a more or less diagnosis of diaphragm weakness. But on the other hand, what do you think exactly is its value in assessing breathing effort? Do you feel comfortable if I just do ultrasound and see a thickening fraction of 30%, that this patient is not over or under assisted? How would you interpret that?
Oh, that's a good question. It's the correlation between pressure, force generation and the thickening fraction is real, but it's weak. So this is an imperfect technique. On average, patients who have a thickening fraction of 30% are probably in an appropriate range, but in an individual patient, it's going to vary. And the relationship between thickening and force generation turns out to be very complicated. It depends on the mechanics of the system, the relative contribution of the abdomen versus the chest wall. So this is why I've moved more to pressure-based measurements on the ventilator that are A, they're easier and less time-consuming, and B, I think probably a little bit more directly related to effort. There's also this question about proportional modes. I don't know if you
Yeah,
want
we
to
have
address
1
that.
minute left to address that question, Samir.
Now about,
The
about
role-
the proportion. Yes, it's a good question. The proportional mode today, as you know, we have two. We have proportional assist ventilation and we have the NAVA, neural adjusted ventilation. The difference between all other modes delivered a fixed pressure assist. So if the patient need more or need less, he receives exactly the same. So the concept of the proportional is that more the patient need, more the ventilator assist, less the patient need, less the ventilator assist. It's wonderful mode. It's like the Formula One, you know, it's really Formula One. But to buy your bread, you don't need a Formula One. But these modes are really wonderful in terms of engineering. But in the real life, it's difficult. When we ask how many of you use it, in the real life, in the standard of care every day, you have very low physician use it. So I think it's the future. But I said this when I was resident, more than 20 years ago, we said exactly the same thing. We always call this the new modes. 20 years later, also called the new modes because it's very nice. And you decrease the asynchrony. Now we have data that the asynchrony, whatever the type of asynchrony, induce diaphragm injury, and probably it's the future. The only reserve is the physician. It's not easy to understand and to set. This was one problem. And the other problem is when you put a patient under one of these modes, is always comfortable and you never start your weaning process. You said, oh, it's okay. You don't say what we need to start, and then is another problem. But I like this mode in terms of engineering, but in clinical practice it's very difficult for understand very well. For the problem is the setting, the level of assist. I don't know if you share this one.
Yes, but I really think we have to close the session. I think if I can very briefly summarize it, we had a great session on the diaphragm protective ventilation. We're now in the last 2 decades try to understand what is happening to the diaphragm in our critically ill ventilated patients. And the good thing is that there is a modifiable factor, and that's the role of mechanical ventilation. And I think, as Ewan has just discussed and also published, that both ventilator under assist, ventilator over assist play an important role. And now we have more and more validated bedside techniques to assess respiratory muscle effort. And I think it will become popular and it will become important for our patients in the next few years. Unfortunately, we did not have time to discuss other interventions for the future to protect the diaphragm, but I think this was a very, very good session. Thank you very much. Thank you very much, Professor Gervais, Professor Gallagher, and thank you very much for being here.
Thank you
Very much. Yep.